Short stature. This lecture is in courtesy of our eminent professors, Dr. Isis Ghali and Dr. Nirmeen Salah. What is short stature? By definition, short stature is height or length below third centile, 2 standard deviation below the mean for age and sex. Actually, it is the most common complaint in the endocrinology clinics and in the Diabetes Endocrine and Metabolism Pediatric Unit of Cairo University. Approximately 65% of the total endocrine patients attending the endocrinology units are due to short stature. Measurements taken for accuracy includes weight to the nearest zero point 0.1 kilogram, standing height or supine length to the nearest zero point 0.1 centimeter, head circumference using a non-stretchable tape, sitting height in case of a child, or crown rump length in case of an infant, arm span, upper segment, lower segment ratio, body mass index calculated by taking the weight in kilograms divided by the height in meters squared, and target centile range is calculated. For accuracy of measurements, in infants below or equal 2 years, the length is taken in supine position using an infantometer. And because it is difficult, at least 2 adults are needed using a hard, non-flexible surface, preferably an infantometer. In the case of a child more than 2 years old, the height is taken standing by a stadiometer, the Harpenden stadiometer, and the socks and shoes should be off with the child standing on hard surface. And always remember that when a child, for instance, 3 years old, is measured in both ways, measured supine and measured standing, always remember that there is a difference of 1 to 2 centimeters. There is a 1 to 2 centimeter decrease in height from the supine to the standing position, meaning that if you take his length, you will find the length is more than the height taken standing by 1 to 2 centimeters. Always remember also that mostly and many of the scales used for taking the height are inaccurate because frequent calibration is needed to verify that accurate measurements are taken. What is the target centile range and how do we calculate it? From the age of 2 years onwards, if every child follows his genetic growth pattern, he should be growing within his target centile range and should be growing parallel to one of the centile lines. I will show you this in the next figure. How do we calculate this target centile range? It is calculated by taking the sum of the mother's and the father's height, taking their mean, and then we correct for sex by adding 7 centimeters in boys, subtracting 7 centimeters in girls, and then we plot a range on the curve by putting plus or minus 12 centimeters in boys and plus or minus 11 centimeters in girls. And this will be clarified more in this example. This is a 9 years old boy, and when he was measured, his height was found to be 122 centimeters, falling on the third centile. To calculate his target centile range, we took his mother's height, which was 158 centimeters, plus his father's height, 170 centimeters, taking the mean of the sum by dividing by 2, and then the result, we add 7 centimeters because he is a boy to compensate for the sex. We find that the mean parental height is 171 centimeters. Plus or minus 12, you will get the target centile range, 159 to 183. This means that this boy's height is within the target centile range. How do we know this? If you check this figure with me, this is the Egyptian growth curve for boys, stature for age percentiles for boys from 2 to 21 centimeters. And together, if we check the x-axis, this is 9 years old boy. And if we go upwards along the axis for the 9 years old boy until we intersect the line of 122 centimeters height from the y-axis, you will find that the two lines intersect in this point, which is on the third centile. So the boy's height falls on the third centile. Is he normal for his parents or the target centile range or not? We will go along this centile to see if it falls within the target centile range. Where is the target centile range? This line indicates his mid-parental height, which we have just calculated as 171, and we have plotted it on the curve by this red line, and this is the target centile range by adding 12 centimeters and subtracting 12 centimeters, so the range is from 159 to 183, and revising again the centile where the boy falls, it is the third centile, it is within the target centile range. How to make sure that he is growing normally? We must take serial measurements and make sure that he is falling on his centile all through or parallel to his centile. Okay, what are the causes of short stature? They include normal variance and pathologic causes. Normal variance, as you can see, are familiar short stature and constitutional delay of growth and puberty. Pathologic causes include non-endocrine causes and endocrine causes. Non-endocrine causes on the left include a very long list, starting from intrauterine growth retardation, syndromes of short stature like Turner, Noonan, Prader-Willi syndrome, Lorenz-Mohnbidel, other autosomal and dysmorphic syndromes. All chronic diseases can cause short stature, including the cardiac, the pulmonary, gastrointestinal, hepatic, renal, etc. What about the endocrine causes, as you see on the right? They include the growth hormone deficiency and its variants, whether it is congenital growth hormone deficiency with midline defects, pituitary agenesis, or acquired growth hormone deficiency due to hypothalamic or pituitary tumors, histiocytosis, CNS infections, head injuries, growth hormone deficiency following cranial irradiation, central nervous system vascular accidents, hydrocephalus, empty cell syndrome, abnormalities of growth hormone action, Laron's dwarfism, which is a growth hormone insensitivity syndrome. And by completing the list, on the left, you'll find the other non-endocrine causes, as we've said, the gastrointestinal, the hepatic, the hematologic, renal, immunologic, central nervous system, malnutrition, and psychological. And on the right, the other endocrinal causes other than the growth hormone deficiency. There's the hypothyroidism, the glucocorticoid excess, whether it is due to endogenous or exogenous excess of steroids, pseudo-hypoparathyroidism, disorders of vitamin D metabolism, diabetes mellitus if uncontrolled, and diabetes insipidus if untreated. And so there is a wide list, a very long list of causes of short stature. To simplify, we can see here that short stature can be caused either by normal variants or pathologic causes, and the pathologic causes can be proportionate or disproportionate. What do we mean by that? We mean by taking the body proportions of the child, and body proportions include the upper segment and lower segment, taking ratio of upper segment to lower segment. If it is appropriate for the child's age, then he is a proportionate short stature. If it is disproportionate, then he is disproportionate. Meaning what? If you have a child who is 8 years old, for instance, and you find upper segment, lower segment ratio is 1.3, then this child is disproportionate. But if it is 1, then he is proportionate. Why is this important? Because in the case of a proportionate short stature, you will further divide the causes into a prenatal and postnatal causes. Also, short stature can be classified according to severity. If the height is more than -2 to -3 standard deviation, 80% of the causes will be the normal variance, whether familial short stature or constitutional short stature, and only 20% will be pathologic. But if it is more severe, with a height being more than -3 standard deviation below the mean, this is mostly a pathologic short stature. What about the normal variance? Of course, in every case of short stature, thorough evaluation must be done by taking a detailed history, a very careful clinical examination, always calculate the target height range, always take serial measurements to assess the growth velocity of the child, always assess the bone age by taking an x-ray, plain x-ray of the left-handed wrist, and endocrinologists would also calculate what we call the predicted adult height, the PAH. How is this done? It is done by taking the height, and from certain curves or formulas, the predicted adult height is calculated by considering the bone age. Okay, the normal variants here are being compared, the familial and the constitutional. In case of familial short stature, the child is healthy, his growth is within the target centile range, he has a normal growth velocity, the bone age and chronologic age are the same, meaning that if he is 9 years, his bone age will be 9 years, puberty is within the family pattern, and the final adult height is within the target height range. Okay, what about the constitutional delay of growth? How does it differ from the familial? There is always positive family history of pubertal and growth delay. There is a pre-pubertal and pubertal deceleration of growth along with a pubertal delay. And there is a delayed bone age of 2 years delay than the chronologic age. And there is delayed puberty. And as we said, there is a positive family history for this delayed puberty being constitutional, and usually the predicted adult height being calculated by endocrinology clinics, and the final adult height will be within the target height range, meaning that in spite of this deceleration, we see in the growth of such a child with constitutional delay, finally he reaches a final adult height within his target height range, meaning that he reaches the range of his parents. What about the pathologic short stature? Again, a detailed history, a thorough clinical examination is always needed. Taking the weights carefully and comparing weight for height is very important. Taking the body proportions and considering the growth velocity, not just a single measurement, and also having the bone age assessed by an X-ray for the left-handed wrist. Again, we must always know that we should decide whether the child is proportionate or disproportionate. If the child is proportionate, then the cases can be, or the cause can be either prenatal, meaning due to a maternal, placental, or a fetal cause, or postnatal. Postnatal is psychologic, nutritional, systemic, or endocrine. As you can see in the case of a prenatal, sometimes the cause cannot be identifiable, uh, and then we would name it as idiopathic when you cannot find a cause for the short stature, whether in the mother or the placenta or the fetus itself. And for the postnatal causes, always remember that before rushing into deciding an endocrinal cause, always exclude psychologic, nutritional, and systemic disorders causing the short stature before deciding to proceed for evaluation for an endocrine cause. Regarding the disproportionate short stature, either there are short limbs or short trunk, short limbs like as in rickets, and short trunk as in some types of skeletal dysplasia. This figure uh, will clarify more the causes of short stature, especially the proportionate short stature. As you can see in the figure, you have on the left the during infancy, and on the right it is a continuation of the same figure in childhood. From the key of the figure, you can see that you have the prenatal, from below upwards, the prenatal onset of pathologic short stature, the familial short stature, constitutional growth delay, and finally the postnatal onset pathologic short stature. And you can see the differences between the four. For the continuous blue line, this is the prenatal onset pathologic short stature. You can see that the infant from the start is falling below the lowest curve uh, uh, of normal, and their deceleration is even more during childhood. In familial short stature, the infant and then the child is parallel all through, is below the curve, but is parallel through all through the phase of growth, and finally reaches, as we've said, the target height range of his family who are already short. The constitutional delay of growth and puberty starts in infancy being with normal growth, and then you find a deceleration is occurring, which is very evident during childhood, but finally, after getting into puberty, after a delay, after getting into puberty, the child then accelerates again and has a catch up with normal target height range at the end. As for the dotted red line, this is the postnatal onset pathologic short stature. And as you can see, the deceleration in this type is very evident more than the other types. The child is growing normally during infancy and childhood within the normal ranges of the centiles, but then has a marked and evident deceleration growth with crossing of the centiles. Okay, as we've said, taking a thorough, detailed history and thorough examination is very important to guide in the evaluation of a child, an infant or a child of short stature, because having so many causes needs careful history and examination before rushing into diagnosing endocrinal diseases. From the history, there are some clues that can lead you to the etiology of the short stature, and these are examples, as you can see on the left. History of delayed puberty in parents is an indication of constitutional delay of growth. Low birth weight indicates small for gestational age. Neonatal hypoglycemia, jaundice, micropenis indicates growth hormone deficiency. Dietary intake and nutritional assessment will indicate the undernutrition. Headache, vomiting, visual problems can guide you to the pituitary and the hypothalamic causes, especially the tumors. Lethargy, constipation, weight gain can guide to hypothyroidism. Polyuria, and this is very important, will indicate a renal cause, chronic renal failure, or renal tubular acidosis. Social history will indicate psychosocial dwarfism. Diarrhea and greasy stools will indicate malabsorption. And mind you, in case of celiac disease, which is a common cause of short stature, you will find that there is no actual diarrhea in many of the cases, no change in the emotions, no change in the consistency of the stools, and that's why screening for celiac disease is routine in any case with short stature. Okay, if we pass to the pointers to the etiology from the examination, from the physical examination of the infant or the child, these are examples also on the left. The midline defects, the micropenis, the frontal bossing, depressed nasal bridge, crowded teeth, all will be indicators to growth hormone deficiency. Features of rickets can indicate either nutritional rickets or renal failure, renal tuber acidosis, or malabsorption. The finding of pallor also can indicate renal failure, malabsorption, nutritional anemia, but also can indicate any hematologic disorder. Malnutrition will indicate protein energy malnutrition in infancy, malabsorption in a child, celiac disease, cystic fibrosis. Obesity can be an indicator of hypothyroidism, Cushing syndrome, Prader-Willi syndrome. Metacarpal shortening are found in Turner syndrome and pseudohypoparathyroidism. A cardiac murmur will be found in congenital heart disease. And remember that Turner syndrome, besides the short stature, they have congenital heart disease. Mental retardation can be indicator of hypothyroidism or syndromes like the Down syndrome, the Turner syndrome, or pseudo hypoparathyroidism. Any case with short stature should have assessment of the bone age, and this is very important to assess the bone age. Appearance of the various epiphyseal centers and fusion of epiphyses with metaphyses indicate the sexual maturity of the child. The bone age is assessed by doing a plain X-ray of the left hand and wrist as shown in the photos in front of you. And the sexual maturity is assessed using special atlas, either the Grulich and Pyle or Tanner Whitehouse methods. There are different methods, and of course, this needs experience and training to assess the sexual maturity by using the atlas. One more thing, you must know that a case of short stature, not just the accurate measurements and the calculations that we have said, and the detailed history and the thorough examination and the bone age, but also we need also to do the routine labs to make sure that there is no disease, that underlying disease that can be causing the condition. For example, the complete blood count, the screening for celiac disease, karyotype in cases we have short stature in adult, we exclude Turner syndrome. We do renal functions, we do liver functions, and urine and stool analysis. Further investigations will be guided by any findings that can be found on examination. For example, if you find features of rickets, you will be inclined to do blood gases, for instance, to make sure that there is no renal tubular acidosis and so on. So, accurate growth assessment is essential to eliminate incorrect conclusions, unnecessary intervention, and to have a maximum benefit for proper diagnosis and management. So to start with, we need to do an accurate growth assessment to make sure that this child is really short and is not short just because we are taking an inappropriate measurement or inappropriate interpretation. And this necessitates the following. First, we need to take an accurate birth date from the parents, not just the birth certificates, because the birth date can be different. زي ما حضراتكم عارفين ساعات يبقى الطفل مسجل شهادة ميلاد مسجلة بعد تاريخ الميلاد ببضعة أشهر، فلازم نتأكد من الميلاد الفعلي للطفل من الأهل. We must take an appropriate history for the birth date. We must take the weight very accurately besides the height or the length, because it indicates if there is an underlying disease like nutritional disorders. We must be able to take the parents' height and to calculate the target centile range accurately. Sexual maturity is very important to evaluate by the bone age, as we've said. The accuracy of the anthropometric measurements, what we call the accurate oxology, is very important, and this can be achieved by using accurate and calibrated tools. And knowledge of how to do a graph interpretation is very important, as we have explained in the previous slides. The two most common causes of short stature are familial short stature and constitutional delay of growth and puberty. which are normal variants of growth. And the growth patterns often can be distinguished from one another, but some children have features of both. And this is very important to realize because this is a common finding. Sometimes you have a child who has constitutional on top of familial short stature. Yani he has a familial short stature, but also has constitutional delay of growth and puberty. Underlying nutritional and psychological causes must always be considered. It is very common in our community, and any serious systemic disease can cause growth failure and must be excluded before proceeding to evaluate an underlying endocrinologic cause. طبعا من الحاجات اللي هي لازم تبقى excluded from the start زي ما حضراتكم عارفين even لو ما فيش features clinically is the hypothyroidism. So it is wise to do a thyroid profile with the labs at the start. These are the growth Egyptian growth curves available. These are for the boys and these for the girls. زي ما حضراتكم شايفين الثلاثة اللي فوق دول بتوع الانفنتس اللي هم showing recumbent length and head circumference and weight for age and then weight for recumbent length والثلاثة اللي تحت اللي هم for the children from after infancy from 2 to 21 years. You will find from left to right, this is the linear height, this is the weight for age, and this is the body mass index. And these for girls. These are useful links then because you really need some more illustrations and animations to make it more clear for you how to take proper measurements in infants and children and also how to assess a case with short stature. I really advise you to use these links and I'll be very happy to receive any questions from you for more clarification. And thank you very much for your listening.